Buenos dias. Good morning, ladies and gentlemen. I'm very happy to welcome you to our live transmission from Buenos Aires. We are here in Argentina. It's 9 o'clock in the morning, and we are very happy to welcome you here in the big ballroom and also at home in front of your computer. And it's especially an honor for me to stand here at Professor Mario Zernotti's conference at the 8th Cochlear Implant Meeting for Emerging Nations. We have an outstanding lineup, and we are very happy to welcome all of you. And it's a big honor for me to introduce my personal great friend, Professor Shinichi Usami. Professor Usami graduated in the year 1981 from the Hirosaki University in Japan, and he did then his ENT residency there. In 1986, he spent a full year at the Bayers College in Houston for basic research. So he started all his basic research already many years ago. He has an outstanding experience in genetics. And in 1999, he became chairman of the Shinshu University in Matsumoto. And he was chairman for over 21 years. In 2020, when he needed to retire from the clinical ENT chairmanship, of course, he started a new career, and right now he's professor for medical genetics in the Research Institute of Matsumoto. So the way is still in front of us. He will do a lot of work. Professor Usami is member of the high prestigious Collegium Otorinolaryngologicum Amicitia Sacrum of Corless. He's a member of the Barani Society and, of course, member of several Japanese ENT societies. He published more than 300 reviewed papers and is not only an excellent surgeon and ENT doctor, he's an outstanding skier and he collects butterflies. So I'm now very happy to have him on stage to see the genetic footprints in our nations. Please, Professor Usami.
Thank you, Bami, for a kind introduction. And also, thank you for inviting me, Mario, to this exciting conference. And thank you also for giving me the gift for such a long journey. It took me 30 hours to get here, but something very special experience for me. So today's topic is genetics. So why genetics are necessary for hearing loss patient? Answer is simple. For the best practice for the patient. This is the answer. Sorry, this is my also my message. And hearing loss does not occur without a cause. The most common etiology is genetic. So you already know that genetics is very important to treat or the patient. To discuss etiology, unbiased sample are needed. In Japan, genetic testing for deafness has been covered by social health insurance since 2012. Hearing loss patients now have access to genetic testing as a clinical test. Therefore, Japan is well suited for collection of unbiased sample. Currently, the analysis of 63 gene using next generation sequencing is underway. Recently, we published a paper summarizing the results of 10,047 Japanese patients with hearing loss. The most remarkable results obtained in the comprehensive study was that data allow the clarification of the genetic epidemiology from congenital to late onset hearing loss for the first time. So this slide shows a diagnostic rate. The diagnostic rate differs each age group. Approximately 50% in the prelingual onset group and about 30% in the juvenile young adult onset group, and about 20% in those with onset after 40 years of age. Interestingly, each group showed a different kind of causative gene. Each color represents a different gene, so you can see the responsible gene is quite different between a congenital group and the late onset group. This slide shows responsible genes in the Japanese hearing loss population. As you can see in the slide, GJB2 is the most prevalent causative gene, and the major commonly found gene variants such as CDH23, SLC2604, STLC cause deafness in 30 to 40% of cases. The remaining case of hearing loss are result of various rare gene variants. We found total 51 gene and 1,236 variants are involved in Japanese hearing loss population. So now you may think that this is the data from Japan. So which is the other side of Earth. So you may think that you have a different type of etiology. So the question, are different causative genes involved in each country? The answer is no. We have similar frequently observed causative deafness genes. Although the causative gene differ depending on the analysis method and population, GJB2 indicated in blue color is particularly frequently in all countries, and similar major genes such as SLC2604, myosin 50A, STLC are observed. You can see the data from Japanese, American, French, Netherlands, Spanish, Czech, and I cannot see Chinese and Czech and Ashkenazi Jewish. And we have reviewed the reported GJB2 variants in different populations and consider them from a perspective of human migration. The mutational spectra are known to be ethnically specific, which reflects a founder effect. The 35-DLG variants indicated by blue, which is predominantly throughout Europe, Middle East, North Africa, and North and South America, and Australia. While our 235-DLC variant indicated in orange is frequently found in East and Central Asia. So you can see the big difference in mutation. So this is the story of human migration. The slide shows phylogenetic tree based on chromosomal haplotypes. So as you can see, human originate in Africa and began their journey around the world a million years ago. Finally, the human reached the Argentina. And at some point during human migration, a mutation occurred, and we have inherited it. So haplotype analysis indicated that 35 Delg, blue variant, frequently found in the population with European ancestry, occurred 11,000 years ago. With regard to the 35 Delc, indicate in orange, variant frequently found in East Asian population is estimated to have first occurred and at around 6,500 years ago. So this is a CI conference. So what is the genetic background of a CI patient? You are very much interested in this question. And this is our data. And genetic screening successfully identify causative gene variants in deafness gene in 60% of congenital hearing loss population. You can see in the left figure, and 36% of postlingual hearing loss patient. This is our data. So quite many patients is due to a genetic defects. So I'm very interested in whether we can get a similar result or not. So this is a genetic background of CI patient collecting from 10 hearing group center. We undertook saliva sample based genetic marker study in collaboration with the hearing group. We received DNA sample from 10 centers and performed next generation sequencing analysis and found that various causative genes are also involved in CI or ES patient. As you can see in the slide, more than 50% we can find the responsible gene. Thank you for sending a sample, Gavila. And Mario, is this Mario? Maybe 20 years ago. Recently, we performed genetic analysis in collaboration with Professor Raji in Morocco. Surprisingly, the causative gene was identified in 70% of the congenital hearing loss patient who received a CI. This high percentage may reflect a high consanguineous marriage rate. You can see various different causative genes are involved. And again, still, GGB2 is the number one. So what are the benefits of genetic testing? Genetic testing is important for prediction of future audiograms, prediction of CI outcome, electoral and audio processor selection, choosing appropriate rehabilitation programs, and also important for future therapeutic intervention. So, genetic and the first benefit is genetic testing can predict future audiograms. This figure shows the hearing level of each age group for each gene. So with regard to progression, in the case of GJB2 and STLC, indicated by green, hearing is rather stable. On the other hand, hearing loss due to CDH3, SLC2604, KCNQ4, mitochondrial 30 to 43 A2G mutation, myosin 7A, and mitochondrial 1555 A2G mutation is a progress in nature. And genetic testing is important for prediction of CI outcome. When the genetic background is involved in intracochlear etiology, there is a potential for a good outcome after CI. Therefore, it is important to identify the region involved inside or outside the cochlea by identifying the responsible gene. So I would like to explain a good example. GJB2, known as the most prevalent causative gene among the CI patient. So GJB2 is encode the protein connexin 26, and this protein is known to be localized in the cochlear and is thought to participate in potassium ion recycling in the inner ear. A series of reports indicated that children with GJB2 associated hearing loss who received CI showed a very good outcome. GJB2 is highly expressed within the cochlear, such as organ cavity, lateral wall, spiral limbs, but almost nothing in the spinal ganglion. So therefore, good CI outcomes are expected. This is the auditory behavior development after CI evaluated by Lillia's auditory questionnaires. As you can see, the left group is the genetic etiology. And you can see the majority of the patient show a very rapid and good development of hearing behavior. In contrast, the left group is other etiology group. This group is comparatively slow development. So you can see hearing behavior development is dependent on the etiology. Also, genetic testing are important for decision making for simultaneous bilateral CI. Simultaneous bilateral CI is getting popular and popular, and genetic diagnosis is important for decision making. If the parents has a genetic mutation in a gene specifically expressed in the inner ear, simultaneous CI is strongly recommended, as the intracochlear etiology appear to be a very good prognostic factor. And benefit number 3, electoral and audio processor selection. So genetic testing is sometimes important for decision making for ES using longer electoral. This case, 13 years old female, this patient hearing loss was identified at the age of 5 and started wearing hearing aid. Her hearing loss was progressive, and she used a hearing aid, but amplification is not sufficient for communication. Genetic testing reveal her hearing loss is due to CDH23 mutation. This figure shows the natural course of hearing loss due to CDH23 mutation. The average hearing for each age group indicates that hearing loss is progressive. So we decided to use a longer electrode to cover the low frequency in the future. And as you can see in the slide, the tip of the electrode reached the 250 Hz region, but residual hearing is well preserved. And the hearing with the ears is around 30, 40 dB. And now she enjoys playing piano using her low frequency acoustic hearing. So, and the genetic testing is also important for choosing appropriate rehabilitation program. This is a relationship between ITMAIS score and etiology. As you know, the ITMAIS score is a very good marker for developing hearing behavior. And etiology can be divided into 6 genetic, unknown, congenital site megalovirus, anomaly, syndromic hearing loss, and cochlear nerve hypoplasia. So as you can see, the auditory behavior development differ for each cause of hearing loss. And the genetic group had the best development of auditory behavior. So sometimes we have to use a visual input in addition to auditory vowel therapy. So from that point of view, etiology is very important for rehabilitation as well. So finally, the genetic testing is getting very important for the future because gene therapy has started last year, and the preliminary data showed very good outcome after gene therapy. And of course, molecular diagnosis is mandatory for gene therapy. So this is my summary. Genetic testing is necessary for the best practice. Thank you for your attention.
Dear Professor Usami, thank you so much for this outstanding lecture. It's unbelievable. I started with cochlear implants 92. This was all science fiction. And now we have gene therapy, and you're an integral part of that. So it's really an outstanding topic for our everyday work. Are there any questions from the audience? Any comments? Professor Hagen, please.
So if I understand correctly, this is also very important for the counseling of the parents if you have your genetic analysis.
Yeah, of course, genetic counseling is very important. So we have a genetic counselor, in addition, ENT specialist. And sometimes for a difficult case, I always consult the Department of Genetics. So we are together doing genetic counseling for the parents.
But if you have a good residual hearing in a patient and you counsel on a complete coverage, insert a long electrode, maybe there is a discussion with other colleagues who would recommend
we have to think about advantage and disadvantage. And most of the patient is coming to the hospital because of the insufficient amplification by hearing aid. And we always telling if they have some genetic mutation, then I'm telling the natural cause. The patient hearing is getting worse. So let's think. Okay, I'm telling the patient, let's think the future audiographs, not the current audiogram. So to give the best solution, we are discussing. And the majority of the patient decided to use a longer electrode for ES.
But in other centers, for example, in US, if you have such a still very good residual hearing, would recommend a short electrode.
Yeah.
And then after your information, you have to expect a progression of the hearing loss. So this could be some sort of conflict.
Mm-hmm. And too short electrode is not good, but medium length, such as 24 millimeter electrode, may give us a very good result. So 24 millimeter medium length electrode is also acceptable. But to get the perfect results, we always recommend to use a longer one. But of course, some patient chose the medium length, of course.
I have one final question over there.
Good morning, Professor. Thank you for your presentation. Here in Argentina, we have two families that they have the association between connexin 26 and connexin 30. What happens? I know that patient, but what happens at the future with that hearing loss? In heterozygosis, you understand me?
Honestly, I'm not sure.
Could you repeat the question? So two different kind of gene
Yes.
are involved in one patient.
Heterozygosis, connexin 26 plus connexin 30.
Okay.
What happens with their
GJB26?
Yes.
Yeah, sometimes we encounter such a patient. So based on our data, 3% of the patient are due to double two causative gene. So it's a very complex matter, but 98% of the patient we can explain only one single gene. So we just focus on the particular single gene. And of course, in the future, various kind of gene therapy for each gene will be developed. Sorry.
Till this moment, both families has flat audiograms, not profound.
Mhm. It's sometimes difficult to predict their future audiograms.
Thank you.
Sorry, it's important to follow up every year.
More than 10 years follow-up, both families.
It's
Flat,
progressive? Stable?
no, stable,
Okay.
one family, the other, and their kids.
Yeah, that's important information.
Thank you.
Thank you very much, Professor Usami. A big applause for this outstanding data.
Thank you very much.
Yes, we move forward. So we are live on air. So we transmit directly all over the world. Like now, the people here don't realize that so much here in the Grand Ballroom. So hello again at home in front of your computer. And you know, this is within the hearing series. And we will start now later on the hearing roundtable. And yeah, I'm very proud to introduce my following colleagues, but first the hearing introduction. Yes, welcome again. So the Hearing Network for Experts was founded in the year 2008. We are a group of different researchers, of medical doctors, of surgeons, of speech therapists, of physicists, of electrical engineers, and our aim is to work together and to help the patient. So to get the very best out of all these implants, of the genetics, of the active mid-ear implants, of the cochlear implants, of the brainstem implants, and all what will be achievable very soon, the robotic surgery. And we are a global network of 36 centers working together. Usually we meet once a year to exchange our data and to exchange our research. And also here this year in Buenos Aires, we are together to share our experiences. We did a lot of innovation. We are a very innovative group. We are a comprehensive group working together. We are co-active and we educate people. If you look on the internet, you will see our quarterly hearing roundtable. This time of the year now, our quarterly roundtable will be here in Buenos Aires. And the next roundtable, we have not decided in 3 months, but if you look in the internet, you will see all the past, about 15, 16 roundtables in the last years. We set the standards, we write white books if you want to start a new cochlear implant department. It's very wise if you follow these instructions. If you have any questions out there, please join us, please ask us, we try to help you. The meeting right now will be an interactive meeting. You can ask questions via the computer, you can raise your hand via your laptop or PC. It works very, very nice. We will see all your questions here. We are also fully accredited for everything. And now I will pass over to my colleague and friend, Professor Gavilan, Javier Gavilan from Madrid, from the University of La Paz in Madrid, Spain. And he will moderate this outstanding roundtable. And now we will fly, although we are here, but you will fly now to Buenos Aires. Thank you very much.
Well, hello and welcome all, those here in person and the more than 80 people connected right now online. As Professor Baumgartner mentioned, welcome to the 8th World Congress on Cochlear Implants in Emerging Nations, where we are having this special edition of our Hearing Roundtable program. This is a special edition because we usually have these roundtables online, but this is a hybrid event. We have people here in the room, that you cannot see, and we have you on the web that we cannot see either. So it's a difficult situation to manage, but we are going to try to make it as easy as possible. The idea of the roundtable program started during the pandemic, when the only way we had to meet was just online events. And right now we saw that it's a very appealing situation for, especially for young people in need of training. And we have continued with this, and we will keep going on with this roundtable program. And the topic for today will be best practices in hearing implantation for emerging nations. The whole conference has been dedicated to emerging nations, so problems specific for emerging nations. For those of you who are seeing the event here or online, this is the time you can see it, but remember, all roundtables from the hearing group will be already accessible at the hearing webpage that I will mention at the end of our roundtable, and you can find them also in YouTube. So they are all recorded, and you can watch them whenever you want. We have selected three crucial topics for this roundtable for today. We will deal with meningitis, we will deal with cholesteatoma, and we will deal with oral atresia. Why these three topics? Well, basically because they are huge problems in emerging nations, and this is dedicated to emerging nations. This program of roundtables, it's something that we want to be interactive, and we want you to participate as much as possible. The format will be short presentation of a case or two cases from the panelists, and then open discussion during 15 minutes about this topic. And you can ask questions here from the room just by raising your hand. And for those at home, you can also raise your hand in the web chat in the web application from Zoom, or use the chat, the Zoom chat, just to ask your questions. And we will also introduce your questions live in this event. And to start with this interaction and demonstrate that we really want you to participate, I would like you at home or here to ask you to switch on the camera of your cell phones. Please use your cell phones and scan this QR code. I want you here, you all scan this QR code. At home, you can scan this QR code. And once you have this QR code scanned, can you please tell us which country are you from? Professor Usami was the first one. So we have a lot of people from Argentina. Of course, the answers are mainly coming right now from the live event. We have people from Austria, India, Japan, Germany, South Africa, Brazil, Mexico, Uruguay, India. India has a lot of people also here. So I cannot see the number. It's 57. No, the answers. The number of answers. Yeah, they're still answering. Okay. We have people from all over the world. Now, second question. After knowing where are you from, we would love to know what is your field of expertise. And the options are surgeon, audiologist, speech language pathologist, researcher, technician, and other. So can you tell us what is your field of expertise? Good. We have a majority of audiologists. We have surgeons in the second place, and researcher, others, technicians, and speech language pathologists. Okay, so let's move to the main part of the roundtable. That will be, as I mentioned before, a presentation by each one of our three speakers, and then we will have the discussion. And let's start our journey bringing the experience of Germany here to Buenos Aires. Well, we traveled to Germany, to Munich, and took immediately Professor Joachim Müller here to Buenos Aires. Joachim Müller, as you all know, is the head of the cochlear implants and hearing prosthetics section of the Department of Otorhinolaryngology, head and neck surgery at the University of Munich. And well, he has extensive knowledge in the field of general trauma surgery and pediatrics, and his main field of interest is microsurgery of the ear. We are really lucky to have, the hearing group is very lucky to have Professor Müller as a vice chairman of our group and as one of our speakers today. Joachim, this is forward, this is backward.
Okay. Good morning, everybody. I'm happy to see so many people after the wonderful evening last night. A special welcome to the people from Brazil, whom we sat together at the table yesterday. It was a little bit loud, but we enjoyed the company very much. I thought after the loud music, we would another point in the program to have a live surgery of a cochlear implant this morning, but everybody survived with hearing. But now we're coming to the case. And the case is a 35-year-old woman, academic veterinarian, had a pneumococcal meningitis 2 weeks ago. She experienced initially deafness. Then she was presented to the clinic within 2 weeks and had a little improvement in hearing after cortisone treatment and treatment of the meningitis. Her audiogram is on the right-hand corner, and we saw an improvement in thresholds, but not in speech understanding. But before I left to Buenos Aires, I saw her, and the speech understanding was with 20% monosyllabics with hearing aid. Neurologists are not sure if all findings in the MRI are due to meningitis, but maybe also to multiple sclerosis. So there is a need for continuous investigation. The MRI showed a clear difference in the signal of the cochlea. And our question was, what shall we do? So we had her in a close follow-up with weekly and 2 weekly counselings, and we're still waiting for the development, having a cochlear implant scheduled on site. The second case is a 9-year-old child who experienced on 3rd of November otitis media with pneumococcal meningitis. On 9th of November, there was a hearing loss detected in a different hospital nearby Munich. And on 21st, she was seen in the clinic with an MRI control, which was arranged beforehand with telephone contacts. And what we saw in this patient is that we had no signal on the right cochlea and a clear signal on the left side. No, on the left side and not on the right side. And one ear was deaf and the other had a threshold of 35 dB. CT scan showed a little bit of calcification, but not too much. So the impression is that is a partial volume effect and patent cochlea. But under surgery, it turned out that 3 weeks after when we did the cochlear implant, the electrode could not place properly inside. So we had a fibrosis, which was not detectable in CT scan. and drilling and scratching out of the cochlea resulted in the insertion of a medium electrode. That was the maximum we could get in with a surgery that lasted for a few hours. And that's how you change the picture. Okay, time for discussion.
Time for discussion. Thank you, Joachim. Take a seat there. And this is time for discussion. We have Professor Hagen. You start shooting.
Yes, this is a conference concerning emerging countries. And we had yesterday the discussion that there is often a problem in decision making after meningitis. So it's not like in Germany or other European countries that people have to look for financing the cochlear implant and then they lose time. So the only solution, if you know it would last maybe 2 years or 3 years until they get the financial support for the CI, then you have the calcification and no chance. So there was a discussion, should we perform a dummy electrode in the deaf cochlea? Because this is a very cheap procedure and this is not a cochlear implant, but it keeps the chance of inserting a cochlear implant later when the financial situation is cleared.
Good question. The people from emerging nations, because Professor Müller, I don't think he needs to answer this question. Mario.
Thank you, Professor Hagen. It's a very good idea because you propose that every patient suffer from meningitis, especially for pneumococcal, during the next days of the resolution of meningitis, it's under surgery of only electrode without electrical signal inside the cochlea and to close to avoid the ossification. Okay. I think that is a very good option to propose to our authorities, health authorities. But on the other hand, it's important in our countries, the vaccination, because it's previous to this and it's important, but I think that it's a very, very good idea.
Arthur, do we put a dummy?
Well, it's a good idea. We heard that yesterday too in the round table, right? It was a good idea. But I was talking about Brazil. In Brazil, we don't have a waiting list for this kind of surgery. So we go straight forward to the cochlear implant. But if you have a waiting list, probably should go for a solution, middle solution like this one.
Can you bring the microphone to Professor Mohan Rajeswaran? Mohan, I was going to ask you, what about this in India? Do you think this is a good idea?
Yeah, Javier, almost 20 years ago, Professor Milind Kirtane from Mumbai published a paper on exactly the same theme. So what he did was he called it stenting of the cochlea. So he stented the cochlea, when the time that you wait for the financing to give an implant. So almost 20 years ago, he published a paper on this. So we in India now, like Brazil, we don't have a waiting list for meningitis patients, but 20 years ago we did. And we did it. We used to do regularly stenting of the cochlea, like you said, and we used to wait for the funding to come for the implant and then, go ahead with the implant. It's an excellent idea. You stent the cochlea, you take it out and put back the implant. So there's no fibrosis going on. And even if there is a fibrosis around the stent, so you still have the sheath into which you can introduce the implant.
Good. Shak, Professor Shak Said, go ahead. You use the one that works.
Does that one? Yeah, that one works.
Yeah.
Shak Said from London. I think it is a good idea to stent, but the problem is that the longer you delay the cochlear implantation, the more you lose your spiral ganglion cell population. So it doesn't matter if you've stented the cochlea. If there is a delay, and this is very much a feature of meningitis, as you all know, you're going to lose your spiral ganglion cell population. So inevitably, a delay will compromise the outcome, even if you've stented the cochlea. But as an interim measure, I think it makes sense, yeah.
Okay. Thank you very much. How much time do we have? Because we're saying just put a dummy because you don't have time. How much time do we have? Joachim?
Well, I would guess that we have seen ossification and severe fibrosis after 3 weeks where the cochlear implant was not to be placed in. But can I add a comment on this?
You can add any old comment you want.
Thank you to Argentina for having us here. But in terms of stenting, to remove the stent and replace it with an active cochlear implant, do not underestimate the surgical procedure. This bears particular difficulties to get the new electrode in when you remove the stent. For that, the electrode originally used should be the longest and thickest you ever can find. And if it's bilaterally, you should implant bilaterally. I remember a paper from John Graham on meningitis, where he did a simultaneous surgery in a similar situation, and one side was presenting good hearing, and the other side, due to the spiral ganglion cell situation that Jacques mentioned, did show poor hearing. So there are more facets, but on the end, we should be quickly within, for me, 3 weeks, if no hearing recovery is and no functional results coming.
So we all agree, so we have 3 weeks and we need to use something, of course. I mean, if you want to go inside, you need to be, the previous one to be thicker and longer. And I want to introduce one more member of the panel, is Professor Rajeswaran from Chennai. Ranjit is the Director and Chief Audiologist at the MERF Institute of Speech and Hearing of Madras ENT Research Foundation, a center with the most sophisticated infrastructure with the latest cutting-edge technology to serve the patients. And his special focus is on hearing restoration and hearing implants. We're proud to have Ranjit among our members at Hearing. And I want you to ask you something, Ranjit. How do these patients, these that may have a dummy or don't have a dummy, but they will get ossification around the cochlear implant, how they will perform from an audiologic standpoint? They are doing the same as normal cochlear implants? They're doing worse? Can you tell us something about that?
Yeah, one of the most important point when it comes to the outcome is the patients with post-meningitic but patented cochlea, the performance is much better than patients with ossified cochlea. And to be very specific, what Jacques mentioned, the spiral ganglion population plays a major role in terms of the quality of sound perception in this case. Another factor that would affect the performance is other additional disabilities post-meningitic, in case they have a auditory processing disorder, central disorders. So that definitely affects the performance of these children. Now, in patients with patented cochlea post-meningitic, outcomes are very much comparable to children with non-meningitic profound hearing losses. But when you have patients with ossification, as the ossification keeps increasing, and if you look at the number of spiral ganglion cells going down, the performance deteriorates over a period of time. And another bigger issue what we have is with respect to the quality of lifestyle post-meningitic. So, and the behavioral issues some of the children go through, parents go through, has a significant impact on the performance. So by and large, it all depends on how early we do an implant so that we can restore more number of spiral ganglion cells. And number two, the ossification that plays a major role on it. And three is comorbid, like additional disabilities. So these are the three conditions. But in general, the children with cochlear implant, post-meningitic ossification performance is poorer compared to children with non-meningitic cochlear implants.
So we have to adjust expectations with the family concerning these child, right? Now, you've mentioned, Joachim, you've mentioned about MRI and CT. Do we need both? Do we need both CT and MRI? We can have just one?
Well, MRI is the most important imaging technique for the meningitis to detect the cochlea. You see in the different sequences different changes over time, and this is the way to detect it early. However, access to MRI sometimes is difficult, but CT is, to my understanding, not sufficient enough.
Okay, so the question is, can we have access to MRI in emerging nations? I mean, you're here, but you don't really have the problems of emerging nations. You are the top of the pyramid in the emerging nations. But in your countries, in the emerging nations, do we have problems, Arthur, to access to MRI?
In America? In Latin America, you mean?
Yes, in Latin America.
I don't think so. I guess in Brazil and I guess in Argentina, Mexico, we have a lot of MRI machines. So just saying what he said, we do, of course, MRI in those cases, but we also do CT scan. I guess when we combine those information, we have a better view and a better hint to what is going to happen inside of the surgery. But back to your answer, I don't think MRI is a huge problem. I think MRI with anesthesia is a problem. That's a problem. That's the age of, age of 9 maybe with no anesthesia, but if it's a baby, may become a problem. Anesthesia and MRI are something that quite difficult.
Mario.
And it's important that in other countries, not in Brazil, Argentina, but in other countries could be the necessity to choose only one. In that case, only one is MRI.
MRI.
Definitely.
Good. And is there anything we can see in the MRI that can tell us whether this is going to get more ossification or not that much ossification? Do you use contrast MRI or do you use Joachim?
Yeah, with contrast medium.
And you can tell whether this is going to be more the chances of getting ossification are higher or not? There's nothing?
Not a radiologist, but if I see the changes, I cannot predict whether this will be from the labyrinthitis more ossifying or less ossifying. As soon as we see the changes, it's time for surgery, and we want to do the surgery before we have any changes like a fibrosis.
Okay. Now, yes, we have Shaq. Go ahead.
Yeah. I think where you might have some indication from the imaging is if it depends on the pathogenesis of the meningitis. If it's hematogenous, i.e. bloodborne, that's when you get the cochlear wipeout and it's really bad. But there's a small group of patients with meningitis who the cochlear effect has come from the cochlear aqueduct. And if you look at your imaging, there is just a change near the basal turn of the cochlea, and they have a better prognosis. So I think we published on this many years ago. I think the pathogenesis makes a difference as well.
Good. Let's move into surgery. I mean, surgery is difficult for patients with ossification. Is there any specific technique we can choose to get to get the longest insertion that we can obtain? Is there something you can recommend? Joachim.
Well, be patient, take your time, and never give up.
This is new for surgeons.
Yeah, but it is. And well, you have different options that are published. One is basal turn drill out. And to our experience, this is in terms of result not working very well, and the electrodes are switched off. So drill out is not an option. Drilling the channel, being early, and then scratching with a hook and with a needle the fibrosis tissue out, and use the insertion test devices and the dummies or catheter, whatever you can find to free the fibrosis from inside the cochlea is welcome. And a last chance, which is for the surgical procedure, the step of choice is then first try scala tympani and then try scala vestibuli. Sometimes you're lucky and insert into scala vestibuli. And the third option goes back to Montadon. This is apical cochleostomy, and to insert the electrode upside down. However, you must ensure that your cochlear implant system allows for reprogramming in the upside down version, and then you can achieve full insertions. There had been a third way from Italy with Coletti described. to insert the electrode via the middle fossa into the cochlea. But also there in the long-term run is fibrosis reported with poor outcome, as well as the split electrodes that had been introduced by Bredberg in the late 90s. All the upper electrode coils were switched off over time, and the performance was also poor. So take your time and free the cochlea as long as it takes.
Good. Mario, is there a place for double array electrodes?
No, in my experience, no. But I fully agree with Professor Joaquin that to do surgery in a patient after meningitis, you need training, the best training, because you can drill the basal tympanic scale, the vestibular scala, the insertion in the second term. All the options can be present in the surgery of meningitis. But I need to explain that nowadays we have a rigid electrode provided by Medel to put inside the cochlea to remove or to open the rest of fibrosis in some cases, and inclusive to measure that length that you can put the electrode. This is a very, very useful tool to do surgery in meningitis.
Okay, just the last question before, I mean, the format of this roundtable will be the discussion, and after the discussion we have the reveal, where the speaker will tell us what he did. So we will find if we were right or not. So before going to Professor Müller's reveal, I just want a short answer for your side. Did you have any patient where you were not able to insert the electrode, where you had to go back to the same situation as before, Mario?
Let me.
Yes or no? No, I want the answer from all of you.
Yes,
yes.
Definitely.
Arthur?
Yes, the same. Yeah,
yes. Joachim?
Yes.
Yes, me too. I had the problem once. So there's a place for ABI in these patients. Yes, okay. Now, Joachim, tell us the end of the story.
Yeah, well, the end of the story was discussed in the roundtable nicely. I want to remind you that also severe otosclerosis can present ossification and obliteration of the cochlea inside, and we will find similar situations. Martin Patscheider, who is head in Brixton and comes out of our school, will present some nice cases he has done in Italy in his talk today. This is a situation where you sit, you try to use the dummy electrode and squeeze the electrode in, take out the fibrosis for sometimes hours, and sometimes you insert a regular electrode, sometimes you end up with a short electrode. Fortunately, the situation is rare in Germany. I mentioned apical cochleostomy. This is how it looks. You drill the basal turn, you find white masses inside the cochlea. You cannot see the lumen. Don't drill too far, otherwise you will enter carotid artery. And then you take out the incus. You can remove the stapes crura, or you believe it, and then below the cochlea from process, you enter into the cochlea, and then you can insert the electrode upside down. What we have seen after COVID, Sarah Draut from our group had published this. We have seen an increase of musculitis and endocranial complications by the factor of 10. So we have nearly weekly seen sinus thrombosis, meningitis, and this is due to pneumococcal vaccination, to pneumococcal infections that has not been decreased by vaccination, whereas Haemophilus and other meningitis types have decreased by vaccination. So in the end, meningitis is a danger for delay, And I think also in Europe, we will see it more frequently because the observations after COVID showed us more otitis media with complications. Thank you.
Thank you very much. Now, let's move on. And we are keeping our journey, and we are getting now closer to Argentina because we are now going to travel to Brazil. So with our machine of teletransportation, we have you here, Arthur. Arthur Castillo is a professor at the hospital clinic of the medical school of Unicamp. He's the professor at the Faculty of Medical Sciences and member of the Ethics Research Committee at Unicamp. Arthur is mainly focused on otology and especially on the surgery of hearing rehabilitation and cochlear implantation. And as a group, the hearing group, we are delighted to have you as one of our newest members representing the Campinas Center in Brazil. And Professor Castillo will deal with another big problem in emerging nations, which is the management of cholesteatoma. Arthur?
Thank you, the hearing board. Thank you, Javier. Thank you, Peter. That's my old photo with 17 kilos more than I'm today, but okay. I'm going to present something that's quite common in our countries. That's the cholesteatoma, how I manage that. Still, we have a lot of patients with cholesteatoma, I guess, in Latin America. I don't know if in Europe you have so many, but we need to manage those cases first to control the disease and then to rehabilitate the hearing. So just to introduce you, cholesteatoma is a destructive and expanding growth consisting of keratinizing and squamous epithelium. We all know that in the middle ear. Or associated with the mastoid. The treatment for cholesteatoma usually involves surgery. I may say always involves surgery, and we need to remove it. The problem comes when we need to remove everything, or the cholesteatoma itself has destroyed everything that we have in terms of conduction hearing. So usually we perform in Brazil, try to do it in one step to solve all the problem. We don't have time or space to have second, third, or fourth look, as you see in some countries. So we usually go for canal wall down mastodectomy, which sometimes may damage a little bit more the hearing of the patient. So it comes at the end with conductive, mixed, or even profound hearing loss. So in this clinical case that I'm showing to you, it's a very simple, very useful, very day-by-day case. We have a 38-year-old patient with a history of left ear discharge for the last 5 years, getting worse at the last 2 years. And in fact, this patient had all his life problems with the ears, beginning with otitis media, not well controlled otitis media. And this is the classical case that we have. So the patient comes at this age with a lot of infection and ear problems. So also has a hearing loss and tinnitus. So this is a CT and MRI. Usually we perform for those patients only CT scan, but in this case for study, we performed also MRI. As you can see in the CT scan, we have a large cholesteatoma, a large area compromising the ossicular chain, compromising the structures of the temporal bone. And also if you go to the MRI, you can see that there's a high signal inside of the mastoid, which of course is also the cholesteatoma. So for diagnosis, we perform usually on those patients just CT scan. So we went for this patient for canal wall down mastodectomy as usual. So usually we do it like that. In this patient, there was compromising of the ossicular chain. And of course, we had to remove everything. We lowered the canal wall up to the facial level. We had to explore the mastoid tip and also to explore all the promontorial and all those taken tube, all those regions to assure that the cholesteatoma was well removed as the first aim of the surgery, like to have control of the disease. Then we had this audiological result on the left side, which is the line compromised by the cholesteatoma. We have the huge bone air gap. And now I ask you, and probably Javier will go conduct how we rehabilitate this patient. If we use hearing aids, transcutaneous, and then it's with you, Javier. Then I reveal what we have done.
Okay, then you tell us what you did. Okay, thank you, Arthur. So, before taking questions from the audience and from the people online, which, by the way, you're very quiet. I mean, the people at home, we usually have more input from you in our roundtable programs. You can just write down in the chat your questions and we'll take them. So Arthur mentioned that cholesteatoma is very common in emerging nations. Joachim, do they have more cholesteatoma than we have? We had more cholesteatoma 35 years ago or 40 years ago than now in Europe.
I'm not sure.
You're not sure?
No.
Rudolf, do we have more cholesteatoma? Less cholesteatoma than before? Because this is my feeling. My feeling is that when I was a resident, we did a lot of cholesteatoma cases, and now we do much less.
There's no statistics, but the feelings is less because the control of the ears, especially in the childhood, is better now. And so you have the early treatment options also in recurrent otitis with all the necessary things. And so maybe 50 years ago, this was completely different and we had more cholesteatomas. So looking to the OR plans, the cases of cholesteatoma go down, in my opinion.
Okay, so it is very common in your practice, Mario.
Unfortunately, yes, for the patients. Because I think that in our countries is probably the chronic otitis media with and without cholesteatoma the most important illness of the year, the middle year. Therefore, in our practice is day by day cases of cholesteatoma in our OR.
Okay, well, I feel myself like 40 years ago. I've been 40 years going to meetings to discuss canal wall down versus canal wall up. And during these 40 years, I've never seen a change in the discussion. Joachim, you say, what does this mean?
Yeah, well, the discussion is going on, and everything has pros and cons. But what we do is that we do surgery on the cholesteatoma much earlier at a lower stage, so to say. I'm not sure if the percentage of procedures where we do canal wall up or follow the way of origin technology has changed too much. But both has its...
Arthur, you said we did a canal wall down as usual. So tell us a bit.
I guess, in my opinion, you need to solve the problem of infection. Usually if you do like a canal wall up, you have the risk of not removing all the cholesteatoma. Of course, that depends on where it is and the size of the cholesteatoma. You have a very small on the promontory, you can easily do it endoscopically, but it's not most of the cases that we see. We have large cholesteatomas. In those cases, in my opinion, you need to go and try to solve the patient's problems at once. In a canal wall down, you can do that. Of course, there's a balance in between the hearing and the removal of the disease. So what we're trying to do now is to remove at once, at one step, and then go for a solution to rehabilitate the hearing, which we didn't have in the past, the solution. So in the past, the discussion was in between hearing and not hearing, but now you can go easily for, not easily, but you can go to a bone anchor solution or a transcutaneous percutaneous solution to solve the problem.
Ranjit, the question is for you. Hearing rehabilitation, what's best for these patients? And tell me what the difference between, tell them what's the difference between canal wall down and canal wall up concerning hearing rehabilitation.
Well, so as Arthur said, the point is removing of the disease. That's a priority. Now, when you do the canal wall down, then you compromise on hearing. That means when I mean improvement in hearing, I'm looking at the difference in the airborne gap, right? If you look at the best results as an improvement post conductive hearing loss, if your airborne gap goes anywhere around 20 decibels, that's a good sign. 18 to 20 decibels. That's a long-term results that you can get. But when your airborne gap doesn't decrease, then it's a bad sign. So usually in a patient with canal wall down, then you don't see much difference in the airborne gap. It's pretty much larger. Now, the question here is like, what is the best option for the treatment? Now, we should also not forget that sometimes, cholesteatoma can reoccur, right? Now, if you look at the cases where cholesteatoma reoccurs, where resurgery has to be done, the airborne gaps keeps increasing, right? And if you have to give a permanent solution for them, so of course you can give hearing aids, but they are not permanent. But if you want to give a permanent solution for them, so I would recommend to go for a bone conduction devices, where even if you do some medical procedures which is ongoing, at least the patient has a constant hearing that is happening. Despite all the medical treatments, there's always a constant hearing for the patient on that side. So, but hearing aid is again a problem. So, what kind of hearing aid we're going to use, and that can also cause some other additional infections in the ear canal, and it's not that easy for the children to wear a hearing aid in those conditions. So, bone conduction, transcutaneous is.
Okay, Mario.
To be honest, in our country, in our region, it's different. The discussion is not kind of wall down, kind of wall up, because we decide to do kind of wall down.
Always?
Because, not always, but
almost
usually,
always.
Yes, a large one, because the problem is not anatomic problem, it's geographic and economic problem, because you do the surgery, but the patient appears 2 years later, not to the second look, the famous American second look to improve the hearing. It come back to the recurrency of the cholesteatoma. Therefore, sorry, but in our reality, the majority of surgeries kind of wall down to take the control of the infection first of all. After that, we can discuss with the patient and counseling with the parents the best solution for the hearing. But this is our situation.
So, agree. Yes, please, and Rudolf. Yes, please.
Well, let me agree with Mario and tell that Arthur is in a rich university, different from us or from Santa Casa. Okay.
But Arthur also said radical cavity.
Yeah, because I think the main problem is just as Mario said, our cholesteatomas are very huge ones, very large ones. And I've heard from an old teacher, Professor Castilho Lopes Filho, that every time he performed a conservative surgery for cholesteatoma, he regrets about that after a few years, because he should go back and operate again the patient and made a canal down mastoidectomy, because the cholesteatoma is very large for us in Brazil, for instance. We see a lot of very huge cholesteatomas, especially on the very well pneumatized mastoids, when the cholesteatomas goes under or behind the cochlea. And that is a very difficult problem to solve, because you have to remove all the cholesteatoma, go into the petrous apex, and after that, how can you preserve the cochlea and the hearing function on these cases?
Okay, we have one question here, Professor Hagen, and then we have Shah Said there. Try to be short so that we can all...
So I understand correctly, you perform the canal wall down because there is a missing aftercare. Patient disappears somewhere and he will never get back. If he has no problem, there is no reason for the patient to come back. But Ranjit, if you say, okay, this is a nice situation, I will implant a bone conduction implant, you have the same problem. If you do it during surgery and the patient disappears, you have no control on your implant. So that's the same problem. So maybe this is critical, and maybe if it's a single-sided cholesteatoma and the patient had a normal hearing on the other side, for him, it's no real reason to come back.
Arthur.
In my defense, I'm not that rich in central Brazil. And I totally agree with you and you. We do canal wall down because it's in Brazil. To reach a specialist, you need to walk or drive 155 kilometers median. So in the center west and north of Brazil, the distances are huge. It's like 1,000 kilometers to drive. So usually we try to solve that at once. And the problem of putting a hearing device, a bone anchor device, it's a problem, but it's not the same. It's quite different problem, I guess. You can put that and you can schedule the patient to return every year, for example. It's feasible. With cholesteatoma, they think they're cured and they go and they came back, as said Mario, years later. So I totally agree with you that we need to solve the problem at once.
Chuck,
the distance is a problem.
Your microphone is not working.
Oh, it is now. I'll be very brief. The canal wall up, canal wall down, 40 years of a sterile argument. That's what I say, sterile. You do the surgery that is best for your patient in your healthcare system, in your country, with your population, and nobody understands that than the person who lives and works in that country. Nobody died of a hearing loss, but people die of cholesteatoma complications. That's what I would say.
Okay, very good. And so size is an issue, distance is an issue, and the discussion is not whether canal wall down, canal wall up, but just try to fix the patient as easier as possible, right? Mario, something to say?
Oh, no. We're discussing about our cases now. In general, I fully agree with Shaq that the problem is the complication, first of all. In this kind of patient, in this kind of country, this is the goal.
So what's the role for middle ear reconstruction with PORPs and TORPs? And I mean, the usual discussion of pathology meetings for the last 40 years. Is there a role for that today?
In this patient, as you can see in the audiogram, of course, the first option is to reconstruct using prosthesis, passive prosthesis, because if the patient can control year by year, for example, but yes, in our hands, it's very usual the reconstruction of these cases with this audiogram.
I guess the reconstruction is can be done, but the reconstruction need more care after the surgery. You need to watch the patient more closely when compared for a bone device. You need, of course, to follow up with the patient with bone device or after cholesteatoma removal. But if you reconstruct the chain, the circular chain with a prosthesis, you need to have a special care with the patient. And even though you create pockets, where in the future you don't have exactly the same control, and there's a huge number of those prostheses that got out in time. After years, you see extruding this titanium prosthesis. That may happen.
So what about the country that give rise to all these reconstructive techniques? Joachim.
Well, we have discussed extensively canal wall up and canal wall down, and we see the picture there, and we haven't spent a word on how to close the situation. So reconstruction of the tympanic membrane and maybe reducing the cavity is also an option to solve the situation. And I remember the All of India conference with Mohan, where we introduced cartilage techniques to a doctor from Sri Lanka, and a few years later, she was surprised that it's also working. So I would say a word in favor of reconstructing the tympanic membrane with cartilage, and maybe think about a reconstruction or reducing the cavity with either palva flap or also cartilage, and then put the prosthesis in. In this case, you would expect a TORP prosthesis, which is especially per se, and the results from our database said that you have a good result in 50%, but it's worthwhile to try, and that's what we would do in a first attempt, to have a cartilage island technique for the closure of the tympanic membrane, which we would need anyway, and then a prosthesis to support the construction and maybe achieve a better hearing and a use for the hearing aid with the prosthesis afterwards. And also in addition, the ear canal has to be extended very largely to get aeration and get a dry ear, which is the second aim after removal of the disease. So first remove the disease, create a dry ear for aftercare, and hearing restoration is the third point in the priority for these patients in many parts of the world.
Mohan.
Javier, I'd like to summarize this argument. This is what I tell my residents. Every time an otologic surgeon removes the canal wall, there must be a small little pang inside his heart. You know, he knows that he's compromising hearing. But sometimes it is better to lose a battle to win a war. Every general knows that. So you always have to have the larger picture in your mind. But it still means that when I remove the canal, for a second, my heart misses a couple of beats because I know that I'm compromising something. That's the summary.
Okay, good. You want to say something, Arthur? You also feel something when you remove the posterior canal wall?
I'm sad, but I had to remove it.
Okay, so the options concerning if we move to reconstruction with a device with a hearing device, is adhere an option?
Is what?
Adhere maybe an option?
Adhere.
Of course.
I
Definitely.
mean, this is not surgery. You don't need to do more during the operation. That was the concerns of the audience. So this may be easier and cheaper or not? Or
yes.
This is a stupid consideration.
No, it's not stupid consideration. It's a very realistic consideration because yes, of course, you mentioned it. It's cheaper and easier. Therefore, no surgery. Okay, I think that it's a very good option in our countries for patients with chronic otitis media when you control the otorrhea, the infection, blah, blah, blah. In that case, arterial is the best option.
You want to say something? The microphone, please. Wait.
Adhere is a perfect solution, but it's expensive. And in my country, I'm from Turkey, at least in my practice, none of the patient can afford for a while. So this is a problem. And then Adhere is not included the reimbursement system. So there's not a solution in Turkey.
Okay. So I think we'll move to, yes, Ranjit, short comment.
Adhere is an excellent solution, but we need to keep two things in mind. Adhere is an excellent solution, but we need to keep two things in mind. One, I think the bone conduction, the indications for Adhere is very important. Yeah. Because if your bone conduction thresholds are within the limits of Adhere amplification, then you can go for it. If it's slightly more than that, then I think Adhere doesn't give adequate benefit. So that's something which we need to keep in mind before we decide Adhere for this patient.
Of course. Okay, thank you very much. Now, Arthur, tell us the truth. How wrong are we?
I guess in this specific case, as nobody would preserve this ossicular chain, but that's why we have done this. So in this case specifically, we have done a bone bridge. I think it's more expensive than reconstruction the middle ear with a titanium prosthesis. But we have done because I think the result is quite good and the prosthesis is very tough for hot weather and the patient can stay a long time far from us, can come from time to check. And usually we do that at the middle fossa because we had to remove a large area of the temporal bone. The mastoid of this patient was quite big. So we had to remove it and we keep it a little bit up position in the middle fossa. We have done almost all of our bone bridges in middle fossa. We like it very much. We have done bone bridge in our service for the last 3 years. We have like 50 or 60 patients with bone bridge. If you need to scan the patient to control, I guess the artefato is quite feasible. It's something that you can deal with in CT scan. Of course, if you go to MRI, it's a little bit more, but with the new one, the 602 is much less than compared to the 601, the last one. And if you use a specific protocol, you can assure very good control if needed. But I need to call your attention that the control of cholesteatoma should be done via the mastoidectomy. That's why we do canal down to have a good view of the mastoid to remove and debris, as Professor Castilho always says. That's our case.
Thank you very much. Thanks, Arthur. And now we are moving We are keeping with our journey, and we are, well, coming back to Argentina. And now we will have the grandfather of the guy in the picture. Because Mario, this is not you. Come on. Try to update your picture.
Both pictures, huh?
And we will have here Professor Mario Zernotti, a great friend, a wonderful surgeon, the organizer of this conference. He's a specialist in otorhinolaryngology with more than 30 years of experience, even though the guy in the picture has 25. He is the professor of otorhinolaryngology at the Catholic University of Cordoba and the otology clinic at the Speech Therapy School of the Cordoba National University. Professor Zernotti is the director of otolaryngology at the Sanatorio Allende at the National University of Cordoba. And right now he's our president at this 8th World Congress on Cochlear Implants in Emerging Nations. And Hearing is glad to have you, even with your age, as one of our active members. Mario.
Thank you.
Thank you, Javier, for the presentation. I enjoyed this journey, really, a lot. Well, the case discussion. This is a male of 24 years old, as you can see, with bilateral aural atresia, because as you know, in Latin America, we have the high prevalence of aural atresia, especially in the countries near to the Pacific Ocean, near the Andes Mountains, due to genetic reasons, no doubt. This patient, you can see the audiogram, but this patient received the first surgery with Baja in the right side in 2010. The second surgery was in 2011 in the left side, as you said, with the same product. She has severe problems with the skin, with the classification of Holger's 3 or 4. And the third surgery was in 14, in the right side, to Baja Connect, change to Baja Attract. But this solution was solve the problem, because they continue the problems in the left side completely cover the abutment, and the right side was poor performance. In September 2019 was the first consultation with us, as you can see there. This is the situation at that time in 2021, this was. You can see here clearly the famous Baja Connect, and the other is the famous slip yet, okay? But in the other side, this is the Baja. You can see the skin cover totally, but totally the abutment in one side, and in the other side, you can see here the change of Baja Connect to Baja Attract, and the result is very, very bad. Inclusive when we test an adhere with the SoftBank, the result was better with adhere than the Baja Attract. Therefore, panel discussion.
Panel discussion. Thank you, Mario. Panel. Okay, you stay here. Panel discussion. Questions from the audience. Why is atresia so common here? I mean, we see very few cases of atresia. Why? Is there a problem of emerging nations, or is there a problem of is genetic?
I don't know. Probably Professor Shinichi will be the solution. No, we'll have the solution. We are working together now study the genetic of this patient, please.
Shinichi.
Yeah, it's interesting to investigate, but until now, no single gene has not been found. So very interesting group.
Yeah.
And how about altitude? No.
No. Yes, because Professor Sinichi said altitude because 2 decades before, Professor Roland Evie from Boston, Harvard, hypothesized that the reason of aural atresia was the altitude, because there are a little studies in Quito, in Machu Picchu, in Puna, in Argentina, and Mexico, and the reason is that those population are between 3,000 to 4,000 meters over the sea level. Therefore, he hypothesized that the reason is the lack of oxygen during the pregnancy. But you know that in Hawaii the prevalence is high. No, it's high, but yes, it's an island. Yes.
So let's do some collaboration. Yeah. Sorry, we will find the course. But
okay,
now nobody knows.
So obviously this is a mess of a case. I mean, it's a big problem. But let me start before we start discussing this case. Would you need to manage also unilateral atresia?
Yes. There are many.
Not with normally or on the other side.
Now, let me tell you, there are many papers, many publications that said that the children with unilateral conductive hearing loss, atresia, one of these, have severe problems of learning in the school. At school. Therefore, I can't remember the origin, but it's a Nordic country that 60% of these children have severe problem of learning during the primary school. Therefore, we need to adapt at here or Bombridge or whatever in these patients. We need to treat the unilateral cases.
Ranjit.
Well, it's a matter of, I think, in general, we need to treat them. One, because it gives a lot of importance of binaural advantage. And it's specifically, we coming from an emerging nations where there's too much of noise around, and localization and binaural summation and is very important for learning, schooling. That's important.
Okay.
But that's not the case in most of them, because at the same time, we don't have funding for that when there is unilateral atresia. So the intervention for unilateral atresia, though ethically it's required, but due to the socioeconomic status and reduced funding and awareness, it was not possible. But it's better to restore hearing on both sides in unilateral cases.
Arthur.
Yes, I totally agree. Rehabilitate unilateral conductive or mixed hearing loss on those cases is very important because of all you said. We go forward and do that. But I guess in Brazil, I don't think we have as many malformation as you have in Argentina, I guess, because we see that, but not that often.
Okay, so maybe it's samba. With this case, what will you do? You.
In this case, we need to. So we have problems with Baha on those patients, the Baumgartner devices, as usual. In the past, we had started with Baha in our service too. We had a lot of skin problems. So probably convert this prosthesis to another one, maybe a solution. But still, the bone anchor solution is something that you need to do. You need to change or pick another one, I guess. That's maybe a solution for that patient.
Okay, let me stop on as usual. We don't like in our countries, we don't have good results with percutaneous devices. Mm-hmm. Is this the same in Germany?
Yes.
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 Shock. Why?
So as usual.
They're so popular in the UK.
Microphone.
Well, it was the first bone conduction auditory implant. If we go back,
but this is not a scientific reason.
No. Let me finish. And it was popularized by a small group of surgeons, particularly one surgeon in Birmingham who shall remain nameless. And basically, I think that if you're Mediterranean or Latin American, why would you have a small piece of metal sticking out of your head? This is, you know, people from Latin America and from the Mediterranean, they dress very well, they eat very well. Why would they have this thing? Whereas in the UK, we don't care about these things. That's why.
Okay, Chris, I want another opinion for the UK. Microphone here.
Professor Ray.
Chris.
Yeah, I agree with Shaq that until 2012, until the bone bridge came out on clinical trial, but the management is education to the patient and to the families to look after the skin. The other alternative is what sort of size of implant did you have? And the design of the implants have changed over time, and the take rate is significantly better. So we do use percutaneous when the bone conduction is out of criteria for the conventional things. So you'd need to look at the ossicular chain. Can you use a middle ear implant or a bone bridge? You know, that's what you need to look. You need to look at an active process. But we use a longer extension, perhaps, and it obviously obviates the what I call a keloid formation. But it's education of the hygiene is one of the major issues. But still, 5% of them fail.
But I think climate, temperature, and cultural issues. I mean, Mediterraneans, we don't like to have something going through the skin. This is something we don't like. But apart from that, hot and humid weather may an impact on skin problems, because you listen to the UK guys and you listen to the Danish guys and the Swedish, and they are all happy with their screw coming out through the skin. And you come here, or you go to Spain, or you go to India, and the situation is completely different. So there might be some geographic reasons.
I guess those skin problems are so true that the companies are moving. That's the end of the story, I guess, because Ponto has moved it to is going to move to Sentio, and Baja has moved it, not moved, but has moved it to Ossia. Of course, there'll be a space for percutaneous, but specific cases where you need a specific amplification, few cases, or you need an MRI control afterwards, very well controlled MRI.
And you're British.
Yeah.
And the next one is you're British.
Yeah. No. But yes. So those companies are moving because transcutaneous is much more likely to be used by a patient in hot weather. It's much easier to use.
Ranjit, why this patient doesn't work with the Baja tract and works with the adhere with the soft band? I mean, this is something Mario mentioned, and I don't see any reason for that. Can you?
Even I honestly don't know what's the reason for this particular case, why they perform well with adhere and Baja tract. I don't have any specific justification for that.
Work. Oh, sorry. You publish a work.
Yes, I will present it later on. Yes, on adhere, but it was the same result. We had the same result with Baja tract than with passive transcutaneous. Same audiologic result, but not worse. I mean,
no, it was similar, little worse, but the aesthetic problem is not. In Latin American population, the aesthetic problem is really important for us.
Okay,
really.
We didn't say a word today about the Soundbridge, about the active middle ear implants. Is this an option for this kind of cases, or you don't like for atresia cases?
I love, but I forbidden to do this. Now, I really, to be honest, Vibrant Soundbridge is a very good solution for this kind of patient, but a friend of mine recommend me keep it simple. Therefore, nowadays I prefer bone bridge to Vibrant.
Good. And coming back to funding, is this funded? I mean, what kind of device have you funded in Brazil?
For we can use bone anchored solutions, but right now only for congenital malformations.
Only for congenital?
Yeah, unilateral or bilateral.
Not for the cholesteatoma case?
No, but we're asking the Minister of Health right now to have this new indication authorized, but it's not authorized right now.
Adhere is also
specifically, you can ask for specific cases one by one, but generally it's authorized for malformations like this one.
And adhesive are also funded?
What?
Adhesive devices, adhere.
No.
No.
No. Here you can use that, but Vibrant, no.
Okay, and Mario, in Argentina, are they funded?
It's founded in bilateral cases, not in unilateral cases, unfortunately. But we use the justice to achieve the processes, because the justice always dictate a sentence in favor of the patients.
And in Germany, the non-emerging nations?
All devices are funded. Adhere, bone bridge, sound bridge, other bone conduction devices. But Mario, you have a new president, so maybe a situation can change.
Probably.
Okay, any question from the audience? And
Professor Hagen?
Rudolf, yes, and yes, wait a second. First here, and then we go there.
So looking to the huge number of piercings in many patients in the nose, in the ear, and they can handle, there's a transcutaneous piercings in the lip and also in the nose. So it's a question, why does it not work behind the ear? Of course, but I was also asking Mario, Vibrant is not possible in this case because the aeration of the middle ear or the mastoid is not enough to bring the Vibrant. But in general, we have to confess that the Vibrant in oral anesthesia, if you have a nice pneumatization, is from the audiological side the best solution. There is, if you cannot do it, but from the audiological point of view, it's a natural stimulation of the cochlea, and you have no stimulation of both cochleas by the bone conduction. So this is another reason you have to mention.
Well, I completely agree with him. Just to add on to what he said, the Vibrant has a better dynamic range. So the better dynamic range is very important for good localization abilities. The angle of localization minimizes. So the
localization is
exactly, the dynamic range in bone conduction devices is a little smaller compared to the Vibrant sound bridge, and at the same time you're stimulating the ear which is affected, so it's not the stimulation that is going for the both sides.
Okay, Arthur, you want to say something?
Yeah, it's nice to remember that Professor Brito from Brazil, he has a series of very malformed ears using the Vibrant sound bridge with very good results, but of course their challenge surgeries. I think he presented in a previous hearing meeting some years ago, the series of VSB and malformed ears. But of course, it's quite difficult.
Well, I think the main issue is that surgery may be much more difficult. I mean, I don't see a real reason unless there's a minor malformation. I mean, with bone bridge, with bone conduction devices, you can manage. Juan Manuel.
Thank you so much for the excellent panel. I come from Colombia. I just want to know, in this case, with perfect bone conduction, I have more than 50 patients with Baja tract that works very well. Of course, some patients, they have skin issues, they have magnet problems, maybe they have pain, but most of the patients are performing very well. So Mario, please tell me what was the problem with the Baja tract? Because the gain of the Baja tract, although in the high frequencies is not the best, but for bilateral atresia, it works very, very well. It's a passive device. But what was the problem with this patient? Interesting case. Thank you so much.
Thank you, Juan Manuel. The answer is very simple. The patient compare all the time, they connect with the transcutaneous, the difference is notorious. Therefore, she wants the Baja tract because it's not the same that the percutaneous.
Okay.
Sorry, but the percutaneous is not working due to the complications.
Okay, good. So one more questions. The title of this roundtable is the best practices. What are the milestones for a best practice concerning patient selection? The steps you go on this journey. What will be for an emerging nation?
No, so the best practice is the same to the other countries. It's not different. The problem is the access to the prosthesis. Nothing else.
Yes, but you have less access. So how do you select when to use the resources you have?
It's very difficult to find the ideal patient, because there is we take in account different situations, economic situations, geographic situations, add to the audiological situations to choose the best prosthesis.
So it's a matter of individualization. It's like always in medicine. Joachim.
Well, I think we have heard yesterday from Mohan how to adapt best practice to the individual situation of a country. And it's an effort which is an initiative of interested people, and then adapting to the political situation around, and continuous work and support over decades to achieve best practice for the majority of the patients. It's a stepwise process, and I think Mohan's talk yesterday described exactly the way to go.
Okay, we have time for one last question. The new version of Zernotti, the one who's more like the picture. Microphone, please.
Yeah, it's working.
Ahora.
Hi. This is not a question, it's just a comment. Something I want to say. Yes, a comment. I think in this country and in South America, we try to do the best all the time. We are not selecting the cases and you deserve this prosthesis and you don't deserve. Maybe the thing that changes is the time that we indicate the implant and we receive the implant, but we are not selecting cases by a hand, and we try to do the best for every patient.
Great. Now, time for the reveal. Tell us what you did, Mario.
Well, the solution between okay, the solution was this. It was the BCI conversion. What is BCI conversion? It's bone conducted implant conversion. During the last OSHO in Denver 2023, a group of experts, Professor Gavila, Professor Castillo, Professor Alvera, sorry, it's something else. I can't remember. Well, we agree that did a consensus on this, and this is the situation of the patient where you can see that the abutment totally covered by the skin. Therefore, this is a grade 3 limit to the 4 degree of Holger scale, and we did the surgery to discover. First of all, to discover the abutment, and after that, we tried to remove it. It was very difficult, and we removed, and the screw is inside. Therefore, we study this, and the result is that this screw has biofilms of Staphylococcus aureus. Therefore, we decide to do the BCI conversion, like you can see here, and after that, to put a bone bridge. Why in 2 times? Because in pathological analysis, you can see that the info is granuloma and biofilms, but by sonication, we discovered the presence of biofilm of Staphylococcus aureus, and infectology decided to use antibiotics during 2 weeks. After that, the video, please. We decide to use this position, stellar position, supratemporal line approach, because you can see that it's the best option. The bone is flat. Second, there is not cells in that part, and it's very easy to put, as you can see here, and the skin in this part, it's excellent for the external part, the samba. You can see now both wings over the bone, and the screw is very easy to put. It's a surgery of 30 minutes, and it's more aesthetic than the Baja, without problems, and the results are, you can see now. This is the result, and These are the results published by our group together with Professor Charaviglio from Mendoza, about 21 patients with our atresia. You can see the pre-op threshold and the threshold in either condition with Baumgartner, and the result was 47 dB of functional gain. And in speech discrimination, this patient moved from, in an ideal condition, 27% to 98% of discrimination. Therefore, in our opinion, BCI conversion, it's very important, but taking account that we propose 2 times to do the surgery due to the presence of biofilms in these cases. Thanks.
Thank you, Mario. Thank you, Mario. Well, we've been here for almost an hour and a half. It's 4 minutes left. And this was a hearing roundtable for emerging nations. And I think we really discussed specific topics for emerging nations, meningitis, cholesteatoma, oral atresia. And you know, the health issues related to emerging nations are different. This is obvious, are different from those of developed economies. And they deserve a very special attention because they affect almost 7,000 million people, which is 6 times our population, the population of advanced economies. So I'm very happy to be part of this conference. I'm very happy to be part of this society. And I think we can expand this as long as we focus on emerging nations, as long as we don't open the conference just for a routine conference. Mario, congratulations for this successful event, for the great organization, and for an outstanding scientific program. You got a lot of H's on top of you since we came here, and we can see from your face. But right now, we're very happy to be here in Buenos Aires. Thanks a lot. And we are almost out of time. I just want to thank you all for your attention. I want to thank the people at home, even though they didn't ask a single question, but I hope some of them were still awake. I want you to visit our webpage. We would love to have you there. You can find us, the hearing, at www.hearing.com. You can find the hearing preservation calculator, the counseling platform, the feeding tool. Excuse me. Okay. You can find also the quality standards in children, adults, and older adults. Those quality standards are comprehensive documents with an approach to every situation, including general information, rehabilitation, and minimum outcome measurements. And we have the adults and the children and the older adults. As I said, the boost, the hearing boost, is one of our basic pillars at Hearing. You can find it's an educational platform. You can find this also in our webpage. And it contains certified courses like the ones you have here. And remember that our roundtables are recorded. All roundtables are recorded, including this one. You can find them in YouTube. And you all, especially for the young people here in the audience and at home, you can get accreditation if you go to boost at hearing.com. You can get CPD accreditation for this educational activity. And as you probably know, we are a very active group. We have been in Las Palmas this year, just taking into account this year, we have been in Las Palmas, we have been in Vienna, we have been in Buenos Aires. Actually, we're in Buenos Aires. We're going to Rome for the Pulitzer Society, and finally we will have the Arabic conference in Abu Dhabi in October. And also in October, the hearing will be present at the Africa Summit on Hearing Impairment in Nairobi, Kenya, along with the WHO, which is a summit for increasing the awareness on hearing loss in developing countries. And finally, remember, we will be back, not to Buenos Aires, but we will be back online for the second part of the bilateral cochlear implantation. We did a first part, a roundtable on bilateral cochlear implantation in June this year, and it was so successful that we are going to put it together again with new topics, with an answer question from the previous edition, and that will be December 5 at 3 p.m. Central European time, as the usual time of our roundtables. Well, thank you very much. Please send us your doubts, your questions, your comments to our webpage, and we'll be more than pleased to contact you and answer your concerns and be in contact with you as much as we can. We hope to see you live again soon, and we hope to see all people in their houses in the next roundtable. Thank you very much, and goodbye.